Talking about football earlier, I'm going to say, although I'm talking about England today, I'm actually Welsh, and this is the first time that Wales are in a football tournament since 1958. This will be the first time in my lifetime I get to support my country, so you can miss one tournament just for us. I'm here from the Health Foundation today. You may not have heard of us. We're a UK-focused charity. We have a fairly large trust fund that gives us a certain amount of money every year, about £30 million every year, to invest in improvement projects within the NHS, within our health service. So we'll work with a number of frontline staff to develop ideas and then spread them across the service, either around improving productivity, which I'm talking about here, or improving safety is a big focus for us. And the two are obviously linked. We also fund a lot of academic research in different universities or organisations. And for the last 2 years, we've been setting up our own in-house internal research. And because of our independence, we're able to say, add to the commentary around national debate about what the government is saying or what other parties are saying, and try and just provide an unbiased view of what the true story is. So I'm going to talk through today one of the big challenges that we're facing in the English NHS, the health service at the moment, which is the challenge that it is more or less set itself, which is to make productivity savings over the next 5 years to make sure that we maintain the range and quality of services that we provide for our patients. So I'll start with a bit of background. I'll then talk about why this challenge is so difficult and finish with some of the ways in which the NHS is focusing on this challenge. We're halfway through what we at the Health Foundation describe as the decade of austerity. It's 10 years of more or less flat spend per head. I guess the blue bars are the last 5 years. So the amount that we spend per head of population now is more or less the same as it was 5 years ago, accounting for inflation. So we are spending more on the health service, but pretty much been taken up by the growing population. And obviously, as a population ages, chronic conditions rise, new technologies come, that adds to the cost of that. So we're having to make up a lot of savings through productivity. We've had 5 years of what was called the Nicholson Challenge, named after the chief executive of the NHS for the last 5 years. And we've now got 5 years planned. Because it's predominantly a tax-funded health service, we know what the budget is for the next 5 years, and that's a hard budget. So we know that for the next 5 years, spending will just rise with population growth as well. So we have had 5 years of high productivity growth required, and we've got another 5 years ahead of us with all the quick wins that we might have got gone. So it's pretty tough. A few numbers here. This is looking back at what I described as the Nicholson Challenge, when we had a QUIP program, which was about quality, innovation, productivity, and prevention. And each hospital across the country, each provider of health services was tasked with making a plan to make these QUIP savings. And you can see the first few years. Is my pointer? Do I have a pointer? Yeah, anyway, the first 3 years, you can say quite high numbers, the 5.85 billion a year as the estimated savings, but the most recent year that we have there, 2014-15, is less than half of what we achieved in any other year. So we started well, but very worrying signs more recently, indicative of some of those quick wins being made and not being sustainable long term. The target was about a 20 billion saving. We made 17, so it was a good start, but didn't quite get there. Looking forward, I mentioned that spending per head is fairly static, so any other extra costs have to be made either through productivity savings, which is what we're aiming for, or what we're trying to avoid is a decline in quality or the range of services offered by the National Health Service. And this is a scale of challenge that we're talking about. We've got pay and pensions rising every year. We've got a change to the way our pension system works next year, or this year that we are in now, which is going to be a big hit on hospitals that they're going to have to cope with under the funding stream that's set up. Drug prices rise, as they do in all countries, quite substantially. And all of that represents what the size of the challenge we're facing is. So in 2014, NHS England, who run the services, they're responsible for commissioning the services, set out its vision for the next 5 years, which it sensibly called the 5-year forward view. And they said, based on those cost pressures, just to maintain the quality of service that we have now, the NHS would need an extra £30 billion if it just provided services in the way that it needs now. That's off a budget of around £100 billion. So you're talking a 30% increase. However, if we could achieve different levels of productivity, and they modelled all this through, then we could bring that down. So around 1% would fall to 22 billion. If we could achieve 1.5% productivity, and I'll talk more about what this means, it'd be 16 billion. And their final scenario was if we could achieve productivity savings of starting at 2%, rising to 3%, then the NHS could maintain the range and quality of services that it offers for an extra 8 billion. I'll give you one guess as to which scenario the government went for. So we've got an extra 8 billion. 2 to 3%, how challenging is that? Doesn't sound huge numbers. So let's look at what the NHS has historically achieved. If we look at the Office of National Statistics, who are name says what it is, doesn't it? And they collect all of our information. And for the UK as a whole, a lot of information in this line, but effectively you're just looking at the blue line, which suggests that long term, over the last 20 or so years, the health system across the UK has achieved productivity growth of about 1% a year. So long. Sorry? How do you measure productivity? I'll come on to many different ways that you can measure it. It's very difficult, but this is effectively cost-weighted activity. So using HRGs, health resource groups, I don't know if you use HRGs or DRGs here, getting quite technical, but using that to weight the complexity of the activity compared to either the number of staff that you have for labour market productivity or effectively total spending. So it's basically estimating the number of outputs, accounting for complexity compared to the inputs that you've got. So what we've got here, the light grey lines are the outputs, which are rising each year. The dark grey are the inputs, which give you generally productivity growing. But that's rising by about 1% a year long run. More recently, University of York, who do a lot of work in this area, looked at whole NHS productivity and estimated it to be slightly higher at 1.4. Remember, we're aiming for 2 to 3, so we've got higher more recently. But that was looking at the whole NHS, and I not want to get too complex, but the way that our health system works is we have a set of commissioners who are responsible for local populations and purchasing the care for those. So they act kind of like the insurance companies in a sense. So if you look at the whole NHS, then we've seen higher rates of productivity up to 2013-14. But that little 0.5 negative is their estimate for that single year in what's happened among NHS providers. So it seems to be a mismatch of the commissioners are becoming a lot more efficient, but actually providers are struggling. And where we have seen higher productivity, it's because although output has been growing faster than input as per the definition, it's been relatively modest compared to what we've had before. So we aren't doing huge amounts of new extra activity for the restrained budget, it's that it's rising just slightly more than the budget that we've got. Over the last couple of years, we've started looking at productivity ourselves at the Health Foundation, and using more recent data, we've looked at just the acute hospitals, who account for about half of what we spend on services provided to patients. And just like York that had that one figure for providers showing a drop in productivity, we find a very worrying trend that over the last 3 years, productivity within the acute sector, the largest part of the NHS, has fallen consistently over the last 3 years which has undone some of the early productivity work that we had before, which means that our productivity now is more or less where it was 5 years ago, and we need to increase that to 2 to 3%. You mentioned about how do you measure that, and there are many, many different ways of measuring it. NHS improvement will point you to that last one, which is at 1.4%. But the important thing in here is whether you take our lower value, which is just looking at acute hospitals, NHS improvements, we're still a long way from that 2 to 3% that we're aiming for. So it doesn't sound like a lot, but when you put it into the historical terms, our health system has never achieved that over a sustained period of time. It's not a problem just for the healthcare sector as well. The UK is really struggling with its productivity growth across the economy at the moment. It's another busy slide, but I think 2 lines to pay attention to. The dotted line at the top, this line here, was our whole economy productivity growth, again as measured by the Office of National Statistics, from the period 1971 up to 2007. So you're going around just over 2%. The red line here is our productivity more recently. And you don't need to see the numbers, it's below 0.5, but you can see it's substantially lower. So you're asking a health service to achieve a productivity growth it's never done before in an environment where the whole economy is struggling with health productivity. And any health economist will tell you, based on William Baumol's work, that it's always going to be harder to achieve higher productivity within health services than you can in the whole economy because it's service-led. You can't replace what a nurse does with a machine as easily as you can maybe on a car production line. So there's a very depressing scene set. Let's see if we can have some optimism. I always struggle with optimism when I do these presentations, but I try. This is quite a busy slide again, but when you're talking about how you measure productivity, it's important to account for a number of things. So local factors that you can't control with, just the shape of the hospital can often have a big difference, whether your ward is long or thin or the size of it, different parts of the country. The type of trust, so if you're doing predominantly newer, more complex operations, you'll struggle to make efficiency savings compared to a hospital that's just doing routine hip replacements, for example. You need to control all of that, and then you can get an idea of what the trend rate of efficiency is, but crucially, the variation in efficiency. And this is what NHS Improvement, who are the new body who've been set up to support the 5-year forward view, support providers to achieve these higher rates. They're really interested in this idea of variation. So their trend rate of 1.4% is interesting if you then look at the higher achievers. So across all providers, you've got 1.4%, but go up to the 60%, then you get to this magic 2% that we're looking at. And if you go even up higher, to the 90th percentile, then you're talking nearly 8%. So there is clearly scope for improvement. Add to that, you survey patients, you survey staff, and everyone can see waste in the system. There is clearly some scope for improvement. So a large focus of what the NHS is looking at the moment is how you reduce the variation. You identify the pockets of good practice and spread that across the NHS. Now, the Health Foundation, that's something we're really interested in trying to understand how you can achieve and help progress that. We are also really interested in the idea of variation. Can be quite a complex slide, this one, but basically this is your 10th percentile to the 90th percentile of productivity. The key thing to take away from there, this is from a report we published earlier this year, is that the variation hasn't really shrunk. What we'd like to see is ideally the red line going up to show the frontier shifting, everyone becoming slightly more productive, and the variation within that honing in on the red line, and we're not really seeing any of that. But because of that variation, there is at least some scope for the lower performers to move up. If we can't move that frontier, at least there is some scope there. And I mentioned the 5-year forward view. The NHS needs 30 billion, but it's getting 8. So you need to make £22 billion worth of savings. That's the magic number that we're aiming for through 2 to 3%. Very, very recently, we've got a good idea now of how the NHS is looking to achieve these. And there are 3 key areas that I want to just talk through quickly. You've got the magic 22 billion here. Oh, sorry. About a third of that is coming from what's called nationally delivered savings. You could rename that pay restraint. Effectively, pay is being held flat in real terms over the next 5 years, as it has over the last 5 years. And I'll come on to that in a bit more detail. Leaving 2/3 to be delivered locally. We're a year and a half in and we've made 1 billion. We've got 4 years to go. We've made 1 billion. There's some optimism for you. So we've still got 14 billion to be secured locally, of which 5 billion is going to come from, supposedly, commissioners and looking at some of the variation in the way that care is delivered and rationalising what type of care we should be delivering. I'll come on to that in more detail. And the rest is in the secondary care that I was talking about, those guys that are only achieving no productivity growth at the moment. So a big part of how providers are going to realise some of these savings is some work that's being led by Lord Carter of Coles, which is very much looking at variation in practice across different hospitals in a number of different settings, procurement being a key one. So the variation in how much one hospital pays for a prosthetic hip compared to another one is about twofold. I don't expect you to be able to read this, but it's about £800 in one hospital and about £1,600 in another hospital. There's no reason for that. This is all unwarranted variation. Sometimes you might have more specialised cases where you need a more complex prosthetic, but this is just looking at unwarranted. For the same hip, we're paying 2 different prices. There's only one National Health Service in England. There's no reason that should be the case. Equally, sticking with hips, we've got a variation of the infection rate from the same hip transplant, varies from 0.5% of cases to 4% of cases. Again, doesn't sound so much, but that's 1 in every 200 people having a hip operation in one hospital compared to 1 in every 25 in another hospital. There's no reason that should be the case. And obviously that has huge impacts on quality of the patients, but it also has impact on the amount that that hospital has to pay for follow-on care. So Lord Carter is now working with all hospitals just to understand their data and look at where there are outliers and connecting different hospitals up so that they can see where the practices are different so that they can just adopt better processes where possible. So that's hospital variation. And there's a breakdown of where a lot of that comes from, touching on workforce again, which I'll come back to. Then there's the commissioner side, and we've got a programme called Right Care. And this is all about reflecting data back to commissioners. Another benefit of a national health system is we're able to collect quite a lot of data. You could argue we probably collect too much data that we know what to do with, but we do collect it all, and we're trying to get more intelligent about how we actually use that. And here's one example of one commissioning group and their outcomes for cancer. So very, very quickly see where, as a commissioner, they're doing well and where they're doing badly straight away, and then they can look at either they commission from a different hospital that are shown to be doing better, or they set up the contracts to ensure that that provider improves. And it's all about improving the quality of care at a lower price in that sense. It also might help them see where they are commissioning more activity than their population would require based on the rest of the country, so they can see where they're possibly over-commissioning. So you've got variation in how hospitals work, variation in how commissioners pay for the activity. And then I just want to touch on that other third of it, which is coming from national programs, aka pay restraint. A big part of where those earlier savings came from was this pay restraint. Pay historically rises about 2% a year above inflation within the public sector. It's been more or less flat for the last 5 years and is more or less flat for the next 5 years. Interestingly, as in Germany, we have a big nurse shortage at the moment, partly driven because of that pay restraint, but also partly driven because funding for nurse placements is public, so the government pays for nurse funding at the moment. So when you're going through a funding crisis, one of the things you might do is reduce the number of nurses you're paying for, but then in 5 years' time, you suddenly have a huge shortage of nurses, which you can't increase the wage because that's nationally set. So what we're seeing is a big move from permanent nurses into temporary nurses and agency staff who get paid at a higher rate, but a lot of evidence suggests that you don't get continuity of care, so the quality is lower. So that's a big area of focus for the moment. But we're having pay restraint over the next 5 years as well. And what's interesting with this chart is for the last 5 years, if you look at pay in the public sector, even though it's been restrained, if you compare it to the private sector, where pay has actually been falling on average, the public sector has still been an attractive place to work. So that's where you see this spike, just here, as relative pay in the public sector became higher, so it's still an attractive place to work. But the private sector has started catching up now, and we're just at the point now where private sector is going to overtake if you ignore pension contributions, which are always better in the public sector, and behavioural economists will tell you that most people look at their salary, not their pensions generally. But we're going to get to a point now where private sector is going to be more attractive. And that's the whole private sector, so you might argue that with a National Health Service, we do have some private provision, but for most clinical staff, they'll work in the NHS, and that's their main area of focus. But obviously all the background staff, when we have commissioners who carry out hugely important jobs to maintaining the care and quality of our services, those skills tend to be a lot more transferable. So we potentially might see a big shortage of other areas outside of the clinical workforce over the next 5 years with this pay restraint. So that's making it even more challenging. The idea that you can make a third of that, holding pay flat without any impact on morale and therefore impacting other areas of productivity, is a big, big ask. And this is just showing where a lot of the demand recently has come from. I don't know. You probably won't know about the mid-staff scandal that we had in England, but you can see an effect here where staff were going up. We had financial crisis, the number of staff per bed, number of nurses per bed fell. Around here we had a report about failings in a major hospital in Staffordshire in England. And one of the key recommendations, one of the key findings was a shortage of staff had a huge impact on the quality of care provided. So then we've got this huge increase in the need of staff. All hospitals are suddenly trying to hire more staff. We haven't trained enough staff for that, so that's just heaping cost pressures on this third of productivity savings that we're expecting from savings. I've stopped being optimistic, haven't I? So let's go back to the question, shall we? Increasing productivity in the NHS, is it doable? Well, there is definitely some scope for improving productivity. We can't continue to keep getting worse, hopefully. There is clear variation. We find it in the Health Foundation. Most people who look at it, there is clear variation. We have a National Health Service. We should be able to make use of that and reduce a lot of this variation. There are huge savings to be made if we can support staff to do it. But it's hugely dependent on an already overworked workforce with low morale. So, yes, it is potentially possible, but only if we really protect our workforce and look after them and support them and help them to actually identify and remove the waste that we see and want to improve themselves. And effectively, we have to, because we don't have a plan B. This is showing our current GDP compared to where it would have been without the 2008 crash, there is no money. The 8 billion is all we have. So if we are truly going to protect the services that our population are receiving, then we don't have an option but to achieve it. Thank you very much.
Thank you. Why did they call economics a dismal science? we tend to be a bit pessimistic, but
that's one of the more complimentary things they say about it.
But you turned the corner a bit. I mean, there are ways to improve the situation. Let's take some questions from the audience, but also invite the other two speakers to come to the podium here and to have a general discussion. So please, Professor Skinner and Rodgan. Who has a good question? Yeah.
I was wondering if you were doing at the Health Foundation also projections on the influence of new technologies like data sharing and robots and domotics, and because I didn't hear anybody talk about those things, and there's a lot of belief in it. Could add on, but also could reduce hands-on care and increase productivity.
Yeah, technology in healthcare generally is an interesting thing because in most industries it reduces cost, but in healthcare it tends to increase cost. So it's a really interesting, but it's also very, very difficult to account for. We do a lot of projections of health spending, as do a number of other organisations in England, as I'm sure you can imagine. We started a project working with the Office of Health Economics to try and really get a handle on how you might project new technologies, and it is things like the robotics, but it's also new medications tend to be a huge burden on future. Another thing I didn't mention, over the last 5 years, we've had a lot of medications come off patent, and we're very good in the NHS at generic prescribing, so that's given us quite a few big wins, but that's stopped now, so we expect drug spending to suddenly go up. I thought that was too pessimistic if I talked about that. We did start a project with Office of Health Economics, and we got to the point where it's just really, really difficult. So at the moment, we're only using past expenditure trends as a predictor of future, aware that that's not the best option, but it's really, really difficult to manage. Unless somebody in the room has a better answer for me, then I'd love to talk to them.
And what about the innovation challenges, possibilities in Germany in the long-term care?
I'm always skeptical about technical innovations for long-term care, because I think what we really need is hands-on caregiving. Of course, there is a lot of telecare and telemedicine and telematic and tele whatsoever, and it might be helpful in the area of medical care. For social care, I'm skeptical. And of course, there are things like Paro or the Pflegerobbe, the animals, animals who could talk, and I'm not sure what I think about it. On the one hand, nurses always say, okay, it's good if you have people with dementia who are caring for their stuffed animal. They are more silent, it's easier, and so. But on the other hand, is that what we really want? That we replace a human interaction by interaction with a robot. So,
can I come in? Can I come in on that point? And I'll pick up on your point as well. If you talk to a lot of people, one of the biggest innovations that has happened in long-term care, when you actually talk to the patients, funnily enough, is, I don't know if you call it the Kindle here, but the e-books. Mm-hmm. Which isn't a health innovation, but it's just the fact that you can change the font so people can now read without any glasses or anything, they can comfortably read, has just changed people's lives in care homes more than any other medical-based innovation that has come out in the last 5, 10, 15 years. So it's just really interesting that when you talk to a patient, probably the perceptions of what new technologies can do are very, very different. I think that's a really good point.
Yeah. What about the US?
I think some of the innovations have to do with improvements in primary care. The idea that for many people, they don't need to see the doctor each time they visit. In fact, there's this new kind of trend to assign people with health coaches to meet with them. So that would be lower wages, kind of a different mix of the technology. Closer to home at Dartmouth, they actually have opened up a new clinic where I think it's a half-time physician as opposed to 2 or 3 of them, lots of nurse practitioners. And so that's one possibility. But that's kind of primary care delivery. I think there's tremendous potential for improving productivity through electronic checking in with patients. There's a lot of, I don't know if you've seen some of the work by Kevin Volp, where if there's a sensor on the cap of the prescription drugs, and if the patient doesn't twist the cap off to take the pill, it sends a message to the caregiver that this person isn't taking their medicines. So I think that's a lot of potential, but as you mentioned, economists talk about innovations, capital innovations that substitute for labor versus, that are labor substitutes versus labor complements. Much of what we've seen in healthcare is bringing in new technologies which require even more work from the doctors and even more work from the nurses. So it's not at all substituting for what people are doing. In fact, it adds to their work.
Yeah. I think everything which is similar to routine-like functions that could be replaced by information and communication technology, but there's much more than routine-like interaction in healthcare. That's very clear. Mm-hmm. Other questions from the audience, please. I see a hand there.
Professor Skinner said wealth growth was accompanied by the health. Do the Americans realize that their growth in wealth goes in better health?
So the issue is how wealth connects with health. And I think the Americans are very much aware and concerned about that. In fact, when wages aren't increasing, and as you may have heard, there's some evidence that for middle-aged women and men that in the United States, for white non-Hispanics, that actually mortality rates are going up. Some of this is explained by increased drug overdose deaths and alcohol deaths, but I think there is very much a concern that stagnant wages, poor future expectations about economic advantages definitely has a feedback effect into health outside of the healthcare system. I think that's very true.
If I just may add, in Germany we have mandatory insurance. Everyone has access, in theory, to the healthcare system. Nevertheless, in a city like Hamburg, you have a difference in life expectancy between one quarter and the other, between streets, that is amounts up to 10 years. So it's not only the US where you could say there is those who are uncovered, but even in a system where there's complete coverage, there are huge differences which has to do with things like health literacy, which has to do with health behavior, and of course with the ability to struggle through your health system. So I think that's an issue in all countries.
Maybe turn to the UK story. I was wondering, you say well, a lot of information is available to compare hospitals in terms of quality outcomes, and that is also a method to be more selective and to concentrate probably, or to provide healthcare in certain locations that are functioning very well, opposed to other locations where productivity or quality is much less. Is that being accepted if you would follow that path?
There's an interesting, you were talking about your triangle at the start and suggested that maybe you have less choice in the UK, which theoretically I might argue with, because the way the model has been designed over the last 15 years and why commissioners are there is all about patient choice. So you should, as a patient, be provided all the information that you need to choose which hospital you want to go to. And you can, in theory, go to any hospital in the UK or in some instances across Europe, and your commissioner will pay for that. So you have that choice. The difficulty that we have is actually realising that choice, and 95, I don't know what the figure is, but the vast majority of patients just go to the hospital closest to their home. Majority of people don't want to be able to choose whatever the hospital they want. They want their local hospital to provide the best quality of care. So there's kind of a mixture there of different needs as a theoretical model and then how it actually works on the ground. So there is some recognition, again, in theory, a hospital that is underperforming based on the data that we can show. The theory goes that the commissioner would therefore not buy from that provider. The incentive is there then for them to improve. But how that ties with a patient who could choose to go there because it's their local hospital, it's kind of, it all gets a bit difficult in the wash, so I don't really have a very good answer there, but that's how it's supposed to work. And I also believe that the majority of people who work in a health system anywhere in the world want to do a good job. The majority of them do a good job, and where they don't, it's because they either don't know that they're not doing a good job, and just sharing that data can help see that they need to improve, or they don't know how to improve, which is why I like the ethos of the new NHS improvement body, where it's just going to be supporting people with the tools on how to actually change the way that they run services. If that makes sense.
Okay. Yes, there's a hand there. It's a long way from here.
Thank you. Both Mr. Roberts and Mr. Skinner talked about, well, more or less practice variation, or at least not going close to the RCT figures. Who can address these variations, and how? Is it the government, is it health insurer, or is it patients' organizations who say, well, you should do this or that? And how do they do it? With mirror information benchmarking, or can you also use financial incentives to reduce practice variation and get more appropriate care?
Yeah, I'll go first. I think it's fair to say over the last 5 years, there's been a large focus on the second half of the financial incentives and trying to do it through a payment system. Certainly within acute care, we have a payment for every operation, every unit of activity that they do. And they've been reducing that over time, and they've tried to add a quality premium to it, but that relies on very effective commissioners, and it also relies, again, on providers being able to improve, knowing how to improve, and sharing the information of where they're not doing as well. So I don't think there's been enough of that over the last 5 years, and I think we're changing now more to that collaborative approach, and it's actually, so the Lord Carter work that I talked about, he's now going round to every hospital in the country, sharing the data that it's their data, but reflecting it back to them as a comparison and saying, do you recognize this? These are who you speak to. And it's about setting up those connections with different hospitals now and helping each other. It's a lot more collaborative and helping each other to identify how you can improve. That's the way that we're going now. So ask me in 5 years' time and I'll tell you which one worked better.
Yeah, you have to leave. I mean, have a good celebration tonight.
Happy birthday to your son.
Thank you for coming. Professor Skinner, about variation, who's taking hold of that?
This is a terrific question. At Dartmouth, Jack Wenberg has been studying variation for the last 40 years, and efforts to change it directly have proven difficult. When we talk, I mean, I remember 10 years ago, we talked about reducing payments for high-cost hospitals. That got the hospitals very angry with us, and we started seeing these info editorials, that is paid editorials in the New York Times, attacking our work and suggesting that the reason why some regions are so high cost is because our patients are sicker. And so it's proven a little bit difficult to address it directly. I think the approach of the accountable care organizations in the United States has been one which didn't address, which looked more at potential savings and changes over time and costs. So one example of the ACO, in some sense, being effective is that in McAllen, Texas, which is an area of the United States that we had earlier identified as being a very, very high-cost region, they were able to form ACOs, and there was so much money on the table through waste that the shared savings led to primary care doctors being paid $800,000 a year for the fact that they managed to reduce the costs from where it had been before. Now, the way that we design these ACOs initially anyway, and they seem to be working, is that after about 3 years you lose that benefit. It doesn't continue to flow. The base readjusts. So that's an indirect way to do it, but we still see substantial degrees of variation, and it's a very tough problem to attack.
Thank you. I think we come to an end of the first half, so to speak. But before doing that, maybe one question to you. If you want to give one positive policy advice, very brief, to the Dutch colleagues here in the room, what would be your policy advice, given your experience in the UK?
Wow. I'll let you go first.
So I'm going to paraphrase from an economist named Robert Lucas, who is a macroeconomist. He's not a health economist, but he studied productivity and differences across countries in GDP, and he's observed, of course, as we can all see, enormous differences in productivity growth and in growth generally in countries. And what he said is that when he sees inefficiency, he looks at it in a different way. He sees the tremendous potential of fixing that problem because it is fixable. And I think with people sort of thinking about it carefully that they can do it. So when I see, I actually view I agree with the Eurobarometer ranking of, the Dutch healthcare system as being the best in the world. I think it's a terrific system, but any inefficiency I see in our system in the United States or anywhere else, I think it's fixable, and I think that when we do manage to fix it, that will yield great benefits.
Okay.
I am going to go back to the workforce and say a large part of the problems we're facing is a low morale workforce. I think if you ask anybody who works in any health system, they can find areas where there are ways. They know what the problems are. They may not know what the solutions are. So if you can help just support every person to help fix just one little thing, it'll have a big contribution. But ultimately, people go into healthcare, I believe, because they want to do good and they're passionate about it. So you've already got a workforce who you don't need to instill that in them. You just need to protect it. So it's about looking after the workforce and help them improve. So I'll paraphrase your previous President Clinton, who said, it's the economy stupid, and I'll say it's the workforce stupid. Look after your workforce.
Great, thank you very much. Thank you. We have a break now, and the break is about 25 minutes. I would like to reconvene at 5 minutes to 3, and then we go on with the video conference or video message from the minister, and Gert Westert is then taking over from me. Thank you.